Okay. All right. First, I do want to mention that this is being recorded, so please be aware of that by staying on with us. You are consenting to be recorded. So the first thing I want to do is thank you all for showing up and for participating in this really important community conversation on COVID. We've been doing them for a while, and we will continue doing them on various topics. At the end of the month, we have the Sepsis Alliance, who are going to have a representative here to talk about the crossroads of sepsis and COVID-19. Sepsis is what we see after somebody has an infection, or while somebody has an infection, but not usually right at the beginning moment. Dr. Banach can tell us more about that. But the bottom line is they look a lot alike. And so since they both become emergencies, we want to just touch upon that. I want to thank Dr. Banach very, very much for giving us his time to be here and his expertise. He is an associate professor of medicine, head of infection prevention, and hospital epidemiologist at UConn Health. So he kind of like hits all the buttons, and he's exactly the kind of doctor that you want to have on your side if you're dealing with COVID more than just a very, very mild case of it. And with that, since I'm not a doctor or a medical person, I'm going to turn this over to the person who knows about this stuff. I do want to encourage everybody to feel free to ask questions. We're going to have a lot of our format devoted to questions and answers, because right now there really seem to be quite a lot of questions, which is why we're doing this. Dr. Banach, thank you for coming, and it's all yours.
Great. Well, thank you for inviting me to come and talk to this group. This is a really important group. I think patient advocacy is really critical, especially when we're dealing with a public health crisis. I want to be able to be an asset to this group and help answer questions. So just to give a little bit about my background, as Lisa mentioned, I am sort of the oversight for our infection prevention program here at UConn Health. In that role, I am sort of responsible for ensuring safe care for our patients and for our staff also. I also provide direct clinical care, so I'm an infectious disease clinician. I take care of patients, and including patients with COVID-19. So I've been sort of involved directly in patient care as well, and can speak to some of that. My current focus is more in the infection prevention world, and focusing on ensuring that we're using all the appropriate preventive measures to protect our patients and our staff here at the hospital. That's going to expand. It's expanded quite a bit to go into testing, and I have to talk about the testing situation right now, which is rapidly evolving. And I do anticipate that moving forward, thinking about vaccinations is going to be come into the picture as well. I prepared a few slides as just kind of a high-level overview on SARS-CoV-2. I know this is a group that is quite well versed in the nature of COVID-19. So it'll just be a few slides, but I really want to make sure that I address the questions that are on the minds of everyone, in the group, and try to answer them to the best of my knowledge, and try to help focus on topics that everyone thinks are most important to them. So let me just do a few intro slides. So are you able to see my screen? Okay, great. All right, so just a little bit of word on COVID-19, kind of, again, broad strokes. COVID-19 is caused by the respiratory virus, which has been named SARS-CoV-2. So this is a coronavirus. There's many different coronaviruses that are out there. We have seasonal coronaviruses that affect all of us, typically in the wintertime. What's unique about SARS-CoV-2 is that it is what we call a novel coronavirus. So it's a virus that none of us have had prior exposure to. No, there's no pre-existing immunity to the virus based on exposure to previous viruses. So we're all basically susceptible to this virus. In terms of the way that it's spread, really person to person seems to be the predominant and basically almost exclusive way that the virus spreads. But in terms of the actual mechanism of spreading, inhalation of respiratory virus particles, either through respiratory droplets, which are those larger size particles. Think about them as like kind of water droplets that carry virus. Those are probably the predominant means in which the virus spreads. So an individual who's sick, infected, coughs, releases these droplets. They travel usually up to about 6 feet and can land either in the mouth or the nose of someone who then becomes infected and then can become sick and transmit the virus further. There's also some acknowledgement that small particles, you may have heard a lot of discussion about aerosols and airborne transmission. That's really pertaining to the subset of particles that are the smaller particles, and they can contain virus. Again, the epidemiology and the data that's been evaluated so far, it seems to suggest that although these are out there, they're not the primary way that the virus spreads. It's really through those larger respiratory droplets. And then lastly, there's indirect transmission. So that's from touching shared surfaces that are contaminated with virus. And we'll talk a little bit more about some of those surfaces, but essentially when those respiratory droplets that have the virus in them touch a surface and then shortly thereafter someone else touches the surface, they can inoculate themselves either through touching their mouth or touching their eyes with these droplets, and they can become infected and sick. Inoculation is something that is kind of risen to the forefront with this virus. There's certain receptors that the virus connects to that are in the respiratory and the airways, but also on the eyes. And that's sort of lended itself to think that eye transmission through inoculating through the eyes is definitely something to be concerned about as a potential way to become infected. In terms of who's spreading the virus, so the initial thought, and like a lot of other infections, that the virus is primarily spread by individuals who have symptoms. So think about the person who has fevers, who has a lot of respiratory symptoms like coughing. They were initially thought to be sort of exclusive in the people who can spread these viruses, because that's what we see with other types of respiratory viruses. But what's unique about this virus, SARS-CoV-2, is that there's a higher level of asymptomatic spread. And so individuals who are asymptomatic, who fall into one of two groups, either they're completely asymptomatic, but just carrying virus, or a term that we call pre-symptomatic. So they're individuals who don't have symptoms yet, but in the next 24 or 48 hours will develop those symptoms of COVID-19. But those individuals can have high levels of virus in their body and can be vectors for spreading the virus to others. Sort of in broad strokes, the infection prevention strategy, there's a few different components. First is to basically acknowledge that those individuals who are symptomatic are at highest risk for spreading virus, and to really isolate and have those individuals sort of taken out of the general population to avoid them from spreading virus to others. And then the other measures that, there's got a lot of discussion, including the sort of safe distancing or social distancing, basically trying to spread ourselves out from one another to avoid that transmission from those respiratory droplets. The use of masks and face coverings, and we can talk about that in a little bit more detail, but that sort of works off the notion that even asymptomatic individuals that can have virus, we can block that by wearing face coverings. That prevents sort of the spread of those virus from an asymptomatic but infected individual to others in the community, and then avoiding indirect contact through shared surfaces. That's the primary way that we're doing that, is by washing hands, hand hygiene after touching a shared surface, as well as cleaning those commonly touched surfaces that can contain virus. So just kind of recap on those. Staying home, again, really critical that anyone who has any symptoms that might be caused by COVID-19 be in isolation. Ideally they should be tested and then if positive be put in isolation. But sometimes we generally would recommend that even before testing or before getting a test result, that someone with symptoms stay home until they're feeling better or until they get a test result, that they're negative. And then in terms of who's potentially exposed, The term prolonged close contact really is the focus of identifying individuals who are at high risk of exposure. So within 6 feet of a person with COVID-19 for more than 15 minutes is what the CDC kind of categorizes as a high risk close contact, who would be an individual that may need to quarantine or potentially be tested. The distancing talked about that 6 feet point, and that's really the distance that those respiratory droplets travel, and really focusing on ways to maintain that distance as much as we can as a method for preventing spread is going to be important. Especially thinking about large group settings, particularly indoor environments. They're going to be the highest risk situations, and trying to avoid those to prevent the spread of the virus is going to be critical. And then also lastly about face coverings. So I think, again, the primary goal is that wearing a face covering prevents an asymptomatic but infected person from spreading the virus to others. And I think this picture kind of illustrates that nicely, that it basically blocks a large proportion of respiratory droplets that are expelled from someone who's infected. But there's also benefit to the wearer too. So the person who's wearing it has that extra layer of protection from the outside of preventing themselves from becoming infected. And then eye protection is another one that, like I mentioned earlier, has gotten a lot of attention, and it's something that we use here in healthcare as sort of an added layer of protection to prevent inoculating through the eyes, through touching the eyes with respiratory droplets. And then, maybe we can go into some more detail, but the different types of masks that are out there, I thought it would be helpful to give an overview, because there's always a lot of questions about masks and, what's the best strategy for wearing masks and face coverings. So we've got the N95 respirator masks. Those are really what we use in healthcare. And the reason that we use those is because we do things in healthcare that that intentionally produce a lot of droplets. So doing things like giving patients supplemental oxygen levels, oxygen treatments at high flows, that's going to cause them to generate a lot of aerosols. Doing things like intubating people, putting breathing tubes in them to help them breathe. Those are known to generate a lot of aerosols, and so that's why we use the respirators for those kinds of situations. The procedure masks you can see those are the ones with kind of the cloth masks when we're here with the loops. So these are there's good data to show their effectiveness in preventing spread from an individual who's infected and asymptomatic. They're nearly as effective in blocking droplets as the N95 respirators, and are really kind of what's recommended in the public, in addition to using cloth masks with made of certain materials. We can, if there's questions, we can get into some more detail about that. The cloth masks, have been recently evaluated in laboratory studies in terms of their effectiveness, and there seems to be quite a bit of variability. But there are certain mask materials that can be quite effective in blocking the spread of the virus. And we can talk a little bit more detail about what works, what maybe more we need to be a little bit more careful with. I do want to mention those the masks with exhalation valves. You've probably seen a lot of these. Those valves are actually designed, they're like that picture here on the right side. They're designed to allow people wearing the mask to be able to breathe out comfortably and exhale, so you're not kind of stifling your breath. And they can be a lot more comfortable, but the problem is they don't really serve the function that we're looking for. Remember, the whole goal is that we're going to block our exhalation from an asymptomatic individual who's infected, to prevent them from spreading virus to others. But these masks, which allow that to pass through the mask, really kind of defeat the whole purpose of the mask. So we're really kind of discouraging them. If they need to be worn, they should be covered with a procedure mask or some other type of material to prevent that exhalation from coming through the mask, because that sort of, again, defeats the whole purpose of blocking the exhaled infected droplets in the secretions. And then just a brief word on hands and shared surfaces. So hand hygiene is really critical. Anytime that we're touching something that could be contaminated, we want to think about how are we going to clean our hands. The one saving grace of COVID-19, SARS-CoV-2, is that it's very easily killed with alcohol-based hand sanitizer and the common disinfectants that we use in the house and in healthcare settings. It's there, some of the infections that we deal with in the hospital have like spores, and they're very difficult to kill and require special chemicals. But fortunately, SARS-CoV-2 is quite easy to kill. Again, using sort of common household cleaners and the alcohol-based hand sanitizer, and of course soap and water, also quite effective. So really critical that if you're going to be touching one of those shared surfaces, that you clean your hands using an appropriate means. And then when it comes to shared surfaces, being attentive to those for cleaning purposes is really important. I think about people ask, what's a shared surface? How shared does it have to be high risk? Think about things that a lot of people are touching frequently. So door handles, the gas pump is another one. So if you're going to be pumping gas, a minute or two after someone just handled the pump, that would be the kind of situations where you'd want to either wipe down the handle or at least wash your hands right after you touch it. That's the way to kind of protect yourself from getting virus on your hands and then putting it into your mouth or somewhere where you could inoculate yourself and become infected. Those were kind of the main slides I wanted to open on. I have a few extra slides if there's questions pertaining to certain areas that I can put out there, but I wanted to at least provide that kind of overview as a background, and maybe that will stimulate some specific questions that you all might have.
So right now, and thank you, Dr. Banach, I really appreciate everything that you just shared. It's all incredibly relevant and very important. And I think we have to hear it very frequently to make sure we attend to it. We can either put questions in through the chat if you're more comfortable doing that. I've been trying to find the raise hand feature, which I cannot locate, and I apologize for that. I turned it on in the settings, so I'm not exactly clear how we're going to handle it, but you can clap in the reactions on the bottom of the screen. You can do a clap, and if you just do that icon, we'll know you want to say something. I'll keep my eyes scanning for questions as well. And unmute yourself if you do want to ask a question. We certainly have enough time for questions, and I know that I always come up with questions after these presentations, so I'm sure you guys all have questions too, and they can be on anything related to COVID. It doesn't have to be specifically something that Dr. Banach already spoke about. So do we have anybody who wants to ask a question? Okay, so seeing nobody clapping.
What do we have?
Go ahead.
What do we have by way of evidence in studies regarding when to encourage the patient to stay home versus when to ask the patient to go to the hospital?
Good question. So, so in terms of like a patient who's having symptoms, what are the decisions that we use to guide whether or not they should sort of self-manage at home versus come into the hospital? Right. So, I think at this point, it's a really important question to be thinking about, and our understanding of these, how to answer these, is evolving. One thing that I think at this point in the pandemic that we're recommending is testing is really critical, and it's really important that even someone who has mild symptoms be tested. We have widespread availability of testing here in Connecticut, particularly. So we should be testing these individuals not just for their own purposes, but also for the benefit of the public, that if we identify someone as being positive, we can perform the necessary contact tracing to be able to identify those who are exposed and kind of stop the spread that way. It's also important that if we do identify someone as positive versus negative, it helps us know if we have to be thinking about other things besides COVID. Right now, we're moving into flu season, and while flu and COVID-19 are similar, there's important differences, including major differences in the way that we treat them. So testing is always going to be the first step. When it comes to making decisions about whether patients need to come to the hospital or not, I look at it from two different perspectives. Is this patient, does this patient have a clinical presentation that makes them sick enough to need to come to the hospital? And that usually I gauge based on whether or not they're developing significant respiratory symptoms, certainly any respiratory distress, because those are the two areas that are going to predispose someone to becoming sicker quickly. But then also looking at the patient themselves, do they have risk factors for severe disease? There's certain groups of patients that we know are at higher risk for becoming more sick quickly. Things like older individuals, patients with a lot of the medical comorbidities, immunocompromised individuals, patients with all of those all of those different groups are at higher risk for becoming sick, and I would have a lower threshold for encouraging them to seek care immediately. For a young, healthy person, again, I would encourage them to get tested. If they do test positive, many of them can manage at home just fine. Certainly if they develop the respiratory symptoms or if they had those predisposing conditions that would put them at risk for more severe disease, those are the kinds of factors I would use to kind of triage, who needs to be seen quickly. But if there's any doubt, reaching out, having a person who's sick reach out to their own physician to help make that decision is the way to go.
Hi, I have a quick question.
Sure.
I have a friend, she had COVID one time positive, and then she was negative for a couple months, and then she became positive again. Is COVID a virus that is dormant in the body? Like, how does that work?
Good question. So that addresses like a lot of different areas, some of which we have good understanding of, some of which we're still learning. So we do patients who basically test positive and then later on test positive. They fall into two different groups. Either individuals that are still positive from their initial infection, and that's an important area. And then, the other concern are people getting reinfected. There's no, when you referred to kind of dormancy in the body, there isn't good evidence to suggest that there is live virus that remains dormant in the body for periods of time. We think about that with certain viruses like chickenpox, can lay dormant and then kind of reactivate in the form of shingles. There's some other viruses that can do similar kinds of things, but coronaviruses are not really known to do that kind of thing. So I don't think that dormant virus in the body is necessarily something to be thinking about. But on the other hand, what we do know is that the test that we use most commonly to detect virus is called the PCR test. That actually is a test that detects the RNA, the genetic material of the virus, not actually detecting whether there's live virus and that virus can be infectious, but really just detects the presence of the genetic material from the virus. And what we're learning is that even after patients recover from COVID-19, they're no longer shedding live infectious virus, they can still shed that genetic material for weeks and even months after they initially test positive. So that's been a new discovery. We had previously been doing a lot of repeat testing over and over to see how long it takes patients to no longer be PCR positive, and we found that it can take several weeks, even months, to go from being PCR positive to PCR negative. But that doesn't necessarily mean that they're sort of chronically infected with live virus. It doesn't mean that they're a danger to others in terms of potentially transmitting virus. It just means that they shed that viral material, basically dead virus essentially, can shed for a long time. We sort of knew this from some other types of situations, other kinds of viruses, that this could happen, but it's becoming quite obvious that this is a real issue with COVID. Now, the other piece, that we're thinking about in patients that initially test positive and then weeks and weeks later test positive is reinfection. That's actually gotten a lot of attention recently. There have been a few cases that look like they may be cases of reinfection. So someone who was infected, recovered, and then subsequently developed symptoms, got retested and tested positive. That seems to be more the exception than the rule right now, which is good. I think we're starting to see sporadic cases of this here and there that are being reported. I think we still have a lot to learn in terms of what that means, and more specifically, how the body's immune system responds and protects people from COVID-19. So, that's a big question. After the initial infection, your body makes an immune response, and it makes you immune for some period of time. Now, whether that means it's just a few weeks, months, years, I think we don't really know the answer to that question right now, and that's going to be one of the critical pieces that we're going to have to learn more about in the upcoming months and upcoming years in terms of understanding who is at risk for recurring infections. And also be really important as we think about vaccines moving forward and the type of protection that they're going to offer. So kind of a long-winded answer to your question, but I think your question of patients who test positive and then later test positive, raises a lot of different important considerations.
Thank you.
Okay, Karime, you have your hand up?
How many times can we use the same mask?
I'm sorry, could you say that one more time?
How many times can we use the same mask?
Good question. So I guess it depends on the type of mask, as well as what the mask is being used for and how long it's being worn. So for instance, in healthcare settings, we have different types of masks that we use. We use our standard mask, we use the N95 respirators, and we wear them for very long periods of time. So, for instance, a nurse on a shift is going to be wearing her mask for hours on end without taking it off. Even those N95 respirators, they wear for the entire shift and don't really take it off, except for maybe a few minutes to grab a quick drink or something, or use the restroom, but they're wearing it for hours on end. So in that case, the durability of the mask is going to be less than someone who is kind of using a single mask for maybe a few minutes, an hour here, taking it off, then using it again. So it's hard to give a one-size-fits-all answer to that question in terms of when it's time to toss your mask or wash it if it's a washable mask. Of course, if the mask does get soiled or if you have any concern about the integrity, like it starts to feel like it's falling apart, then that you'd have to address that. And if it's soiled, if it's washable, that would be the time you want to throw it right away in the wash. And if it's a disposable mask, you'd want to toss it. And if you have any concerns that it's becoming, if you take a look at it and it looks like it's thinning out or it's not fitting as well, the loops are becoming loose, you'd want to dispose that mask because it's not really offering the barrier that you want it to offer. It's hard to give a hard and fast number on that one, but those are the kinds of factors that you should be thinking about when it's time to either wash your mask or get a new one.
I have a question.
Go ahead.
Sorry. I have a question. Now that a lot of children are going back to school, any recommendations from you when they get back home, apart of washing their hands?
So, important thing to be thinking about. I actually have a son who's going to be starting first grade on Tuesday. So these are at the forefront of my own mind for personal reasons. But a lot of us are thinking about this as kids are going back to school. I think, the main things to be thinking about are the masks. I think, a child who's going to be hopefully wearing their mask for several hours during the day, I would recommend, washing the mask at the end of the day. Have them have a few backup masks. But at the end of the day, they take off their mask, put it in the wash. In terms of like clothing and, things like that, I don't think that clothes are a major way that the virus is going to spread. For instance, if there's like some particles on the child's clothing and they're walking around, it doesn't seem like that type of spread is really what's perpetuating transmission between individuals. But I think having them come home, change their clothes is probably a prudent thing to do. Definitely the hand washing is going to be the most important thing. So have them come home, wash their hands, they can change out of their school clothes, change into something else, and then kind of, go about their day. I think that's the general guidance, that I would give for kids coming back from school. But the masks, I think if there's any, if you have enough masks to be able to wash them regularly, I think that would be a worthwhile thing to do as well.
Thank you.
Sure.
Okay. Dr. Banach, we have a question in the chat from Karen. There's 3 questions and they're all really good ones. Just a quick follow-up though, you said wash the masks. Can masks effectively be hand washed or do they have to go through the machine?
I think it probably depends on the material. A lot of the sturdy cotton masks can be washed effectively in machines. I think you'd want to make sure that it's not going to like shrink. That would be a concern, that if it's a material that's going to shrink, when you take it out of the machine, the dryer or whatever machine, you want to make sure it's still fitting well and it still provides a good barrier over the nose and the mouth. So I think that would be the biggest concern I'd have. But if you do put something in the wash and you find that when you take it out, it looks like the material doesn't look like it's as intact, I think I'd be try to avoid that in general.
Great, thanks. Okay, so the 3 questions that we have here in the chat. First, is there any information about what the best filter for the cloth masks to make them most effective would be? And I just want to add a little to that. I make cloth masks and I put PM 2.5 filters in. Am I getting near the protection of an N95?
So yeah, that's a great question. And there's actually like some data that's coming out looking at all the different materials that masks are made of. Actually, I think I have a slide that can bring it up. Let me grab that. So there's a study that was just published within the last 2 weeks, study from Duke. Oh, I hope I have it. Yeah, here we go. So this was a study that looked at all these different kinds of materials that masks can be made of. And you can see on the left, they have all the different types of masks, everything from like the fitted N95 respirator, surgical masks, which are like a procedure masks, all the way down the line to cotton masks, bandanas, and then fleece are kind of at the end. And basically, what the study showed was that the fitted N95 respirators provide the highest level of protection, and that's probably twofold. Probably because they have the finest level of material, like interlocking, and the highest level of filtration, but also the fit is really important. So remember, N95 respirators are effective not just because they have the greatest filtration ability, but also because they're fit tested and they cover all the suction areas of all the areas in which virus can potentially spread around a mask. So that's why those N95 respirators are so effective. The surgical and the surgical type masks, the procedure masks, are sort of next in line. They're made of multiple layers of material, which can be quite effective. And when we talk about the 2.5 filtration, that's generally around the layer of those types of masks. They're not the N95 respirators per se, but they're more at the level of the procedure type mask, where they have that filtration ability, which is quite high. And the cotton masks, unfortunately, I don't think this is directly lined up with the different types of material for cotton masks, but what's generally found is that the cotton masks, particularly with the finer filtration, can be quite effective in terms of their ability to reduce droplets. And are generally considered to be the way to go. These other materials like bandanas, which are a much thinner material, and then you may have heard a lot about the fleece gaiters. That type of material. The fleece material is like I think it's like a polyurethane material that's actually designed to kind of absorb moisture in the material, and I think that itself probably renders them to be a little less effective in terms of their ability to serve in blocking droplet transmission. So this is the study that kind of made the news, suggesting that the gaiters are really not the way to go for protection. So again, different layers and all masks are kind of different. But I think using a cotton mask, if you add a filter to it, an external filter, that's quite a high level of filtration for day-to-day use. And it likely is not quite at the level of N95 respirators, but I think for general use in the community, I don't think that's necessarily needed to be quite at that level. I think that the level of filtration provided by a surgical or procedure level mask or like a tightly woven cotton mask is adequate to serve its function.
Excellent. Okay. The second question here is, there seems to be mixed information about testing and its accuracy. Are you able to speak to that?
Sure. So, testing is something that's really evolved quite a bit. We used to have very limited testing, and now we have a lot more testing and different testing options. So when you think about testing, the gold standard of testing right now is the PCR testing that I alluded to earlier, which basically detects the genetic material of the virus. And that test itself is quite sensitive in terms of its ability to detect virus. Now, it's important to remember that a test is only as good as the specimen that's been collected. So that's a big factor too. So ensuring that a good nasopharyngeal or nasal swab is collected is going to be really important in understanding the accuracy of the test and really how sensitive that test is going to be. There have been other tests that have come out called antigen tests. You may have heard about this. These are these rapid tests that are available, and you can get a turnaround time of about 15 minutes for a lot of them. Those are less sensitive in being able to detect the presence of virus. Instead of actually detecting the genetic material, they actually detect the presence of a protein that's on the surface of the virus. So they still do detect virus, but at a lower sensitivity than the PCR tests. But nonetheless, I still think that those have a role. We would use them a little bit differently than we would PCRs. But I think, and those are just becoming available now, and the CDC is now kind of compiling all the data from them and making recommendations on how to use those kinds of tests, the rapid antigen tests. And I would view them to be used in kind of a complementary way to the PCR tests. So I think we'll be using them a lot more. Still the PCR test is the gold standard, which is quite sensitive. But as we think about how we're going to do rapid, more frequent testing on a public health level, those antigen tests are going to be part of the picture. And so even though you have maybe a less sensitive test, having a more rapid test that's less expensive, it still has value in sort of a public health context. So I think we're going to see those being incorporated increasingly into sort of public health, more for like the surveillance testing approach. But the PCR would still be kind of the standard for the diagnostic purposes in a clinical setting.
Okay, and the third question she had, all three great questions. I have a friend who tested positive for COVID-19 but tested negative to antibodies. Can that be explained?
I think the way that could be explained is one of two reasons. Either so basically the immune response is once you become infected, it takes usually up to about 2 to maybe 6 weeks to develop an antibody response. So if you draw blood within that window, you may not get an antibody response at that point. So you may just not have enough time to lapse to be able to produce antibodies, so they wouldn't be detected. The other thing that is coming to light is that it's possible that people with really mild infections or those asymptomatic individuals who are infected may not generate an immune response. I think we have pretty good confidence that people who develop a lot of symptoms and become really sick generate antibody responses, and we have some good data to support that at this point. But there's some concern that those asymptomatic or maybe the minimally symptomatic individuals may not generate an antibody response. And that's important, not just for antibody testing purposes, but also thinking about the risk of reinfection in that kind of situation. And if you don't generate those antibodies, you may not be as protected from reinfection. So again, that's an area, the immune response is something that we still have a lot to learn about. But those are the kinds of things that I'd be thinking about in that type of scenario.
Okay, and before I open up to everybody again for more questions, I just want to ask, will we be able to share the slides from this presentation with the attendees?
The ones that I showed earlier, sure.
Yeah.
Happy to share that.
That would be great. Okay, are there other questions that people have? You can raise your hand at this point. If you unmute yourself, I would imagine you could just ask the question. It will work out just fine. Okay, seeing none, I do have a couple more myself. I just started hearing yesterday about herd immunity again, which I hadn't heard about for months. Where is that all falling in terms of what we need to look forward to?
Sure. So the whole notion of herd immunity is that if enough people become infected, that will prevent further propagation and spread of the virus within the population. It's a theory that's been put out there. That might be a way to reach a point where we're no longer spreading virus within the public or in the community. And it's come to the forefront again. I think there's some some folks involved in some of the leadership discussions and advising the government that are interested in this approach. My personal belief is, I think that type of approach, while we may actually eventually get to the end point, I think it's going to cause a lot of harm to people, and a lot of people who will become sick, and there's a lot of negative consequences to that if we allow the virus to kind of just spread through the population. And I think that the cons of that outweigh the pros, if you will, for that type of strategy. I haven't seen enough data to suggest that that can be achieved in the absence of a vaccine without a substantial cost to patients and the public in terms of morbidity and mortality. So I think it's out there as a potential approach, but I personally have some reservations about that and the consequences that would accompany that.
So when I heard about it, I see it as something that would naturally occur with things like chickenpox or whatever over the course of a long period of time. Has it ever been used as a strategy to create immunity?
We've seen it with things like chickenpox and measles. Like, for instance, before there was a measles vaccine that was widespread, so much of the population would become infected that essentially in a large proportion of the population, and certainly in some communities, there would be enough immunity that you wouldn't have to work, that they'd be basically protected from virus. So the concept has been out there, but I don't think it's ever been used as a solution to an infectious disease epidemic, basically. So conceptually, we've seen that it can work in sort of ending the spread of virus within a community or within kind of a group within the population. But in terms of an answer to an epidemic, I don't think we have enough data or any data to really support that's been done successfully.
Thank you.
I think it depends on how you reach the herd immunity. If it's through vaccine, that's different, because that was the same principle utilized for the smallpox that we know today. I'm curious, once you have given your answer to how you can distinguish who stays home to recover, who goes to the hospital, if the ones that go to the hospital are mostly the at-risk individuals, for an ID doctor, how does he or she prioritize what to focus? Should the focus be on those risk factors, or should it be all of the above? What would be the primary focus in trying to help the patient?
I mean, I think both the risk factors for severe disease as well as the severity of the acute illness are really the two. They go hand in hand, and we factor in both of those in making our therapeutic decisions. Which patients are going to be appropriate for giving antiviral therapies, or now dexamethasone, the use of corticosteroids. Which patients are the optimal ones to select for those kinds of things, and it's based on both who's at risk for developing severe disease as well as who already has severe disease. We know that even among healthy individuals who don't have medical comorbidities, a subset of them will become quite severely ill. If we have a young healthy person who comes in with a clinical presentation with low oxygen levels, significant respiratory distress, we would target them for therapeutic purposes, just like we would, say, an elderly individual with other medical comorbidities who may not be as ill at that moment in time. We would view them in sort of equal footing in terms of their overall prognosis, and that's what would guide our decisions about how to treat them. So it's hard to tease one out from the other, in terms of which is more impactful. A lot of it is also very individualized too, depending on the overall picture of each patient that we're evaluating.
Are there any other questions? I still have my list. Okay, I'll go back to mine. Now that the kids are going back to school, are children more likely to be asymptomatic or less symptomatic than adults? And do we know why? Is it that they're not having as many of the virus cells in them? Like, what's going on with that? And does it lead us to any like really wonderful conclusions, or does it just confuse us?
So I'll say we know a little, but we certainly don't know the whole story at this point. So any response, I'll definitely give that caveat that this is something that we are still learning about. You know, what we do know from some epidemiologic studies is that when they look at spread within households, they've found that older children are more likely to spread virus within households than younger children when they're infected. They seem to be at sort of spreading at the same level that adults spread, whereas younger children don't necessarily seem to be associated as much with spreading the virus to other people in the household. And that's just based on, there's one study from South Korea that was published about a month ago that demonstrated that. And that's more from sort of household contact tracing for patients, or for contact tracing that's done within households of individuals who are sick, trying to discern like who is spreading the virus to who. And it seems to be like those older children are more similar to adults in terms of their risk for spreading virus to others than younger children. But in the contrary, we generally, when we think about the spread of infectious diseases, we think that the more virus that you're shedding, the more likely you are to spread to other people. That's kind of the general thought, that individuals who are shedding a lot of virus are going to be more likely to spread to people that they're in contact. But interestingly, the data shows that young children actually may harbor a lot more virus than older children, and maybe more than adults. So you would think that they may be more likely to spread to others. But so we still have we don't have a full understanding as far as how the virus, the risk of transmission by age groups. But the limited data, that's what that's demonstrated so far. But I think there's going to be a lot more coming, and hopefully that we'll get more answers on that. Again, the predominant thought was that the more virus you shed, the more likely you are to spread it. But there may be more to it. It may actually have to do with the immune system of the person who's infected. If they're younger, maybe there's certain aspects of their immune system that prevent them from spreading, even if they have high viral loads. So again, it's a lot of information coming at us, and not a lot of definitive conclusions, but a really important question that I'm hopeful that we'll be able to answer hopefully soon.
Super. Do we have anybody else with questions? We have a few people just joining us too. Right now we're entertaining questions and Dr. Banach is answering them. So jump right in, and we will also be sharing the recording afterwards with anybody who would like to, re-look at it. I'm going to see if I can get a printed version of it, but I don't think I figured that one out yet. And we will have a copy of Dr. Banach's slides as well. We've had a ton of really good questions here. So are there any others amongst the people who are in our audience right now? Okay, then let me just ask another. Oh, go ahead.
I just have a quick question still
Yes, go ahead.
on children. So I've noticed, and I could be wrong, what's the best way, like if you think a young child does need to get tested? I have had a COVID test just as, a precautionary thing, and it was not fun. And I cannot imagine my 2-year-old sitting still for 10 seconds with something being shoved up her nose. So are there like any other alternative ways of getting tested, or is that just something that you have to do? Is there a good place for pediatric testing?
It's tough. I'm sure anyone in the audience who's had a COVID test knows that it's fairly invasive to have with the nasopharyngeal swab, which is the one that is most commonly used. Well, fortunately, what we're seeing is that there's other specimen collections that are becoming validated for testing. You know, a lot of places are using what we call mid-turbinate swabs, so swabs that don't go all the way to the nasopharynx, but go a little bit closer to the entry of the nose. And they're being validated now as being of comparable accuracy to nasopharyngeal swab for testing purposes. Saliva testing also, I think, is going to be moving to the forefront. You know, many of you may have heard that there is a new test that came through, that was developed through Yale, that has gotten a lot of attention, where they can use saliva specimens to do that PCR test, like I mentioned earlier. So I think we're going to see that coming in the future, and maybe that will be more amenable to the young children, the pediatric populations. You know, what I do know is that some of the testing sites throughout the state, there are some that that do test kids, and I would probably try to find one that has more experience working with kids, it's going to be variable from location to location in terms of you know, the percentage of people they test that are in the pediatric age group. There are other options out there. I think there's going to be more types of specimens that are going to be acceptable in the future as they become more validated using our testing platforms.
Thank you. Do we have any other questions? Yes, you got to unmute. Hold on. Okay, you can go. Whoops. Hold on a minute. You're still muted. Okay, you're good. No. No. One more time. Okay.
Okay. I just have this following question, which you may have answered already, but how will we know when it's safe to take get the vaccine?
Ooh, tough one. You know, there's a lot of enthusiasm about the vaccine, and it's a lot of questions. You know, I think there's been an emphasis on making a vaccine available quickly, and I think that's really important, but as long as it's done safely. So, you know, I think, you know, there's a lot of pressure to move the regulatory process along, and the FDA has moved more quickly on things like medications than it has in the future. And so in terms of the vaccines, you know, what I can tell you is that there's stage 3 clinical trials going on right now. That data is currently being collected. You know, I think once enough of that data has been analyzed to reassure that both the vaccine is effective and that there's no, you know, widespread unforeseen side effects to it. You know, I think at that point, we'll be comfortable with the vaccine. And, you know, I think, you know, my hope is that, you know, the FDA and the other, you know, authorities, there's a lot of like the American College of Vaccine Practices, the ACIP is evaluating vaccines, and there's a lot of different groups within public health agencies that are all evaluating the vaccine and all the data that's coming from it. You know, I think once the vaccine experts feel like there is enough data, again, to support that the vaccine is effective and safe, I think at that point we'll be ready to give out the vaccine. You know, I think whether or not that's going to be at the point in which the stage 3 clinical trials are completely done, I don't know. I don't think it necessarily needs to be, but I think we just have to have reassurance from all of those experts evaluating the vaccine that there's enough data to support that it's safe and needs to be given, or is ready to be given to the public. So kind of a vague answer, I realize that. These processes of approving treatments and vaccines are different now because of the urgency, and appropriately so. But you know, I think once we have enough confidence from the vaccine experts that the data is there, then we can move forward.
Okay, Dr. Banach, your voice got a little bit fuzzy on that answer. So what I'm going to do is I'll talk to you afterwards, and I'll get the name of some of those agencies so that people can follow up and just keep an eye on what they're saying.
Yeah.
By having them, you know, liking them and whatever, and getting their social media outputs. We are at the hour, and go ahead, John.
I think to add to what Dr. Banach had said, for the general public, I think the most simple way is to ask your doctor, ask your primary care doctor in the community. And hopefully they'll be reliable enough to know that what Dr. Banach had said had really actually been carried through.
Yes, I agree with you. I think that our primary care doctors will hopefully give us what we need in terms of guidance. So do we have any last one question, or are we set? Because I actually ran out of questions. You're all lucky. I want to thank everybody for attending this. Dr. Banach, thank you so, so much. You provided a lot of great information and it was more than helpful. And I just realized you perhaps haven't heard what I said. I want to thank
sorry,
you. It's okay.
I had a battery issue. I had to switch devices.
Technology is great until it doesn't work. I really appreciate your giving us your time today, and these were very helpful answers. We do have a recording, like I said. At the very least, I will make notes from the recording that I will send to everybody who was on with us. And if you have any further questions, I'm going to offer to have you email them to me, and I will forward them to Dr. Banach. I'm also anticipating that we will have him back with us at a later date, because things keep changing every day. And it's a very confusing, concerning issue. We will be sending out more invitations for more of our community conversations. So I thank you. And Mr. Shea, do you have a question? You're muted, hold on. Hold it. Can you unmute yourself? There.
This is a wonderful presentation. Thank you so much for putting it together.
Thank you, and thank you, Dr. Banach. Okay, so I'm going to dismiss you all. I thank you, and I hope that you'll keep an eye out for our further emails, because we're doing a lot of cool stuff, and we're trying to keep people informed during these very difficult times. So again, thanks everybody for coming, and we'll see y'all. Thanks a lot.
Thanks a lot.